Hi, and welcome to the Behavioral Health News Spotlight on Excellence series, where we feature exceptional leaders and innovative healthcare solutions that are raising the standards of care in the behavioral health community. My name is David Minot, and I am the Executive Director of Mental Health News Education, the nonprofit organization that publishes behavioral health news and autism spectrum news. Our mission is devoted to improving lives and the delivery of care for people living with mental illness, substance use disorder, and autism, while also supporting their families and the professional communities that serve them. Today, we're speaking with Mary Brewster, Associate Commissioner for Harm Reduction at the New York State Office of Addiction Services and Supports, also known as OASAS. Mary, thanks so much for being here today.
Thanks for having me. I'm excited to be here.
So, to start off our conversation, can you give me an overview of the new division of harm reduction at OASAS? What is its mission, and what is your role as Associate Commissioner?
Yeah, absolutely. So I am shockingly coming up on my 1-year anniversary at OASAS. Time has flown. So I started with the agency in September 22 and am the first acting Associate Commissioner for our division. So this division is brand new to our system of care. But I would be remiss to not say that harm reduction is not new to our OASAS system of care. It's something that our providers have long practiced. But when Dr. Cunningham, who is our acting commissioner, started in the beginning of 2022, one of the lenses and one of the priorities that she really was bringing with her was a focus on harm reduction. So when she started in her role, this was one of the divisions that she created, really taking the opportunity to recognize harm reduction has long been happening in our continuum of care, but really having a spotlight on harm reduction and the work that we do. So our mission is really to take harm reduction to our community, working with our over 1,700 providers within New York State that provide substance use services, helping them implement harm reduction, helping them understand what is harm reduction, and recognizing those opportunities to incorporate harm reduction theory and practices into their services and into their care. Not only am I working with our OASAS providers, but it's also our OASAS system, our staff here at OASAS, getting them to understand what is harm reduction and how to talk about harm reduction and really implement it across our continuum of services. So my role is to lead the division. We are now a staff of 4, so still a very small staff. Doing this work, and the division is really structured around 3 different pillars that we're going to be focusing on. The first is that education, technical assistance, and resources. So again, education is a huge part of my job in the division. What is harm reduction? How do we implement harm reduction? So again, getting out in front of the community, talking to them, doing kind of harm reduction 101. A lot of our providers, this is new for them. So setting that baseline of what is harm reduction, providing technical assistance, not only to our system of care and our SUD providers, but again, OASAS staff. We're a state agency and we have civil service staff. So not everyone who works here comes in with a working understanding of harm reduction. So really working with both our system of care and our staff here at OASAS. And then providing resources. Harm reduction isn't just a philosophy and a theory of care, but it's practical resources that we provide. So we've just launched a huge campaign and project of getting naloxone, brand name Narcan, out into community, getting fentanyl test strips, xylazine test strips out to our community. So really giving that education on the theory of harm reduction, but then also giving the practical tools that you need to implement harm reduction. So that's one pillar of my division. Another is to really focus in on the regulations, structure, and culture of OASAS. So really looking at our regulations that regulate substance use treatment services throughout New York State and making sure that they support harm reduction. Harm reduction is about low threshold care and removing barriers to care. So making sure that our regulations can be implemented in a harm reduction setting and support harm reduction. It's also thinking about our CASACs, our certified alcohol and substance use counselors, making sure that that education that they get has a focus on harm reduction and stands right alongside prevention, treatment, and recovery. And then our third pillar is really focusing in on special projects. This is where we get to have a lot of fun. So I have a couple of initiatives that are running right now through our division, and have my staff member Cameron, who's working on all of those special projects to truly implement harm reduction services. And another part of my role is really incorporating harm reduction services into each bureau and division at OASAS. So making sure that our prevention division has a harm reduction lens that it's using and viewing the work through moving forward. And then really focusing on adding any of those opportunities for assessment, education, and training. This is done through a couple of different ways. So looking at our assessment tools and making sure that our assessment tools are low threshold, that we're only asking our participants and our clients the information that's truly needed to be able to provide them care, providing lots of education. The next month, I'm out of the office almost the entire time, going around the state and talking about harm reduction. What does it mean? And then we have our training opportunities. So we do Learning Thursdays with our Chief Medical Office team to be able to work with our providers to implement harm reduction into their care settings. It's a lot for 4 of us, but we are new, so we are growing. I think that's also the really exciting piece, is that it's not often that you get to work with a state agency where you have an opportunity to create a brand new division. So really taking that opportunity to listen to community. What does community think our division should look like? And responding to those needs of the community.
Yeah, that's great. It sounds like you've been very busy in that first year.
Very busy, yes. Just came back from my first vacation. So
Oh, well
lots of work we've
deserved.
been doing, yes.
So in your own words, how do you define harm reduction, and what is its historical background?
Absolutely. I was very fortunate that I'm a social worker by training. I have my master's in social work and went to a macro practice school. So I'm not a clinician, but have definitely worked in clinical environments. And when I was in social work school, I learned harm reduction, which is not common. That's actually an uncommon thing to get to learn it actually in grad school. And I was really fortunate that I learned harm reduction from Dan Bigg, who is known in our community as the godfather of harm reduction, as a long-term harm reductionist. And Dan taught harm reduction that harm reduction is any positive change. It's really thinking about what are those behaviors that we engage in that we would like to change and make healthier. And really, it's being able to celebrate any positive change that we happen to make. So again, really focusing on those behaviors in our life that we want to change and implementing that positive change. I think it's a theory. So it's that theory of what harm reduction is, but then it's also very practical. So you take that theory and you implement it into your work, and it's helping your clients, your participants, your patients identify that change, helping them be the agents of change, and helping them support any change that they want to make. So that's how I learned harm reduction. Really, again, very simple. Any positive change. And it has a long history. I said at the beginning that harm reduction, the division is new, but the philosophy is not to our OASAS system of care. And really how harm reduction came to us was through the HIV/AIDS epidemic in the early 80s and 90s. Harm reduction really in the United States was born directly out of the HIV/AIDS community. In New York State, one of the first ways that harm reduction was really legalized and embraced was through the legalization of our syringe service programs, at the time known as syringe exchange programs. That happened in 1993. And the reason that these were implemented is that what we were seeing in the HIV/AIDS community is that one of the most perfect ways to transmit HIV and hepatitis C was through the sharing of syringes. And we recognized that this was a behavior change that we needed to create behavior change around people's injection drug use. But if they didn't have the ability to use a clean syringe for every injection, they were going to reuse syringes and share syringes. So in 1993, New York State legalized syringe exchange to ensure that if you were an injection drug user, you were able to get access to a clean syringe every single time you used, and that you didn't have to share those works anymore. So it was really through the HIV/AIDS community that we got harm reduction here in the United States. In other parts of the world, especially in England, they've been practicing harm reduction since the 1970s. It just took us a little bit longer to adopt it, but it really was during a public health crisis that we were experiencing, an epidemic that we were experiencing in the 80s and 90s, that activists said, what we're doing doesn't work. We have to do something else. And what can we do? And harm reduction truly was one of the answers for the problems that they had.
Interesting. So what makes harm reduction services so critical right now? And are they evidence-based and proven to be effective?
Yeah, we are in the midst of an opioid epidemic. In 2021, we don't have confirmed data for 2022, but in 2021, across the United States, over 100,000 people died in 1 year of unintentional drug overdose. If COVID-19 hadn't come along, this would have been the largest public health crisis we had ever had, the largest epidemic we would have ever had in 1 year. In the HIV/AIDS epidemic, it took almost 9 to 10 years to reach 100,000 deaths from HIV/AIDS. We get that every single year. So we're really in a crisis right now. We're in a drug poisoning and an overdose crisis. When right now in New York State, and this is a really sobering statistic that I think one that's really important, one person dies every 5.5 hours of an overdose in New York State. When you come into New York City, those numbers are even worse. It's 1 every 3 hours. When I started working in New York State, or in New York City specifically in 2017, that statistic was 1 person every 8 hours. So we're only getting worse. More people are dying. And I think when you're in a community and you see that kind of loss of life, you have to take a look around and say, we have to do something differently. What we have historically been doing is clearly not enough. So we have to look for all ways, all opportunities to implement any positive change, to help people live another day. And I think that's why harm reduction is so important right now. A huge component of harm reduction is really removing as many barriers as we possibly can to get an individual engaged in care. So an example of that is in my division, we have our low threshold buprenorphine project, where we're funding 15 organizations throughout the state to implement a low threshold buprenorphine project. Buprenorphine is medication for opioid use disorder. It's really the gold standard of medication for addiction treatment. And it used to be that there were a lot of barriers that a person had to overcome in order to gain access to a life-saving medication for a disease, for opioid use disorder. And so part of this project is, how can we remove those barriers? How can we have a person present to one of our programs and say, I have opioid use disorder and I'm ready to start medication for addiction treatment today. And that they leave that appointment with a prescription in hand to start that medication. That's new and revolutionary for us. It used to be that if a person was prescribed buprenorphine and they have a toxicology screening come back and it shows that it's positive for cocaine, they were disengaged from care. Their medication was taken away from them because they were not abstaining from all substances. And we have to recognize that that isn't a requirement for gaining access to medication. I was on a call this morning where we were talking about, would you do that to a person who had diabetes? Would you cut them off from care if their A1C1 numbers were not improving, if they weren't adhering to the nutrition plan that you gave them? No, that's a moment to be able to wrap around even more services to them and say, you have the medication, what else is going on and how can we help you? So I think that that's where we're at right now. That's why harm reduction is so important, and why we should embrace it. And it is absolutely evidence-based. Again, syringe exchange programs started in the United States or in New York City in 1992. They had been happening on the West Coast since 1988. So we have over 30 years now, almost 40 years. That's terrifying. It doesn't feel like it's that long ago. Almost 40 years of evidence to show that syringe exchange programs are effective at decreasing HIV rates and hepatitis C rates. We know that for a fact. Medication for opioid use disorder. So again, those gold star medications, buprenorphine and methadone, they're associated with at least a 50% decrease in mortality, right? 50% decrease in mortality. No other medication that we have does that for a disease state. So that's evidence-based. We know they are effective at keeping people alive. We've seen the peer distribution of naloxone. Naloxone is the medication that is used to reverse an opioid overdose. It's a life-saving intervention with persons most likely to witness or experience overdose. And we know that having peers distribute naloxone has led to that increase in naloxone and is not associated with an increase in substance use. So we know that naloxone saturation helps drive down those overdose numbers, because when someone is able to witness an overdose and has a life-saving medication in their hand, we know that they can save a life. So I think that the research is there, and it really does show that implementing harm reduction and low threshold services helps people engage in life-saving care.
Absolutely. So how does the harm reduction approach align with existing prevention, treatment, and recovery models in the field?
Yeah, I mean, the way that I think about harm reduction is as a continuum, it's a buffet. So prevention, treatment, and recovery are harm reduction. Those are all harm reduction interventions, right? Preventing and delaying initiation of use, that's harm reduction. Pat Zuber-Wilson is our Associate Commissioner of Prevention, and she and I work really closely on what do those harm reduction messages look like, because that's all a harm reduction message. Treatment is harm reduction, right? We just talked about medication for opioid use disorder. That's a harm reduction strategy because it's decreasing risk associated with substance use. Even if a person uses methadone only one time a week, right? They don't go every day for their take-home doses. They just go one time a week. That's one instance that we know that they are using a substance that is regulated, that is a safe substance for them to use. So treatment is absolutely harm reduction. And recovery is harm reduction. Recovery is individualized. That's something that we at OASAS have recognized for a long time, is that recovery is individualized. And it is harm reduction, recognizing, of course, that recovery and abstinence may not be where everyone lands on that continuum of use to abstinence, but recovery is 100% harm reduction. So again, my division doesn't stand apart from prevention, treatment, and recovery. I stand alongside them and working to ensure that all of our services, that the common thread that we're pulling through is a harm reduction message and a harm reduction lens.
Sure. Yeah, that makes a lot of sense. So harm reduction, as you know, it does have its critics and controversies. In your view, why is that? And what steps are you and OASAS taking to increase acceptance of harm reduction among both people who use drugs and service providers?
Yeah, I think that there is this common misconception that one, harm reduction is against recovery and against treatment and is against abstinence. That is absolutely not the case. I think what harm reductionist recognizes that we can't mandate care to a person, that a person has to be engaged in that care. And again, recognizing that treatment and recovery has to be individualized. And that can be very controversial. People think that harm reductionists are condoning substance use, that we are encouraging people to use drugs. I would say that's partially true. We're not telling people to stop using drugs. What we're encouraging is safer drug use, safer substance use. You know, as a harm reductionist, I recognize that substances have been a part of our history forever. Think back to the Grecians and the Romans. They drank wine. Wine is a mind-altering substance, and we have been drinking wine for thousands of years. So substances will always be a part of our reality, and harm reduction recognizes that, so that we aren't trying to eliminate substances. We're trying to minimize any of the risks and dangers that are associated with substance use. And I think that can be very controversial when you're talking about drugs. You know, here in the United States, we've done a really, really good job of demonizing substance use and demonizing people who use drugs. And we see the negative consequences of substance use, especially as we've criminalized substances and the arrests that we see. So I think that it's seen as, how can you support someone using drugs? I'm not supporting their substance use. I'm supporting them using safely. That's our goal. To keep people alive, to keep them safe, so that if they ever decide to engage in treatment and recovery, we are there for them. I hate this phrase, but I think it's really important. A dead person can't recover. And that's why
Mm.
harm reduction is so important to us. So again, a
Sure.
lot of controversy still around substance use, a lot of controversy around harm reduction. 1993, syringe exchanges became legal and they're still controversial, even though we
Right.
have all of the data to show how effective they are at preventing HIV and hepatitis C, which was their intended purpose.
Right.
So the way that OASAS is trying to increase acceptance of this approach is, one, creating a division of harm reduction to say this is something we truly believe in, and the philosophy of care is something we believe in. It is working with our provider systems. I've told all of our providers, invite me into your staff meeting. I'm happy to come in and talk about what harm reduction actually is. What harm reduction isn't, I think, is a really important conversation, but what is harm reduction? To explain it, to, I think, take a lot of that myth out of what harm reduction is and these
Hmm.
preconceived notions, and really explain it from a very basic level of what is harm reduction, why we are embracing it, and how a person can actually implement harm reduction services into their system of care.
Sure. A lot of education and training.
Lots
Um,
of education and training.
so you mentioned about the demonization of drugs, um, and drug users, I guess, in a sense. So stigma, that just makes me think of stigma, and stigma around substance use is one of the biggest barriers for people
Mhm.
seeking and receiving the help they need. Um, so how does stigma play a role in working with people who use drugs, and what steps can be taken to reduce this stigma?
Yeah, I mean, I think stigma is our biggest barrier to working with people who use drugs. They experience stigma everywhere. They have institutional stigma against them. There's social stigma against them, internalized stigma, right? Not feeling valued, not
Mm-hmm.
feeling worth because I'm a person who uses drugs.
Right.
So I come from the HIV/AIDS community, so I'm very aware of stigma. It's been something that's followed me my entire career. I actually remember my first job interview right out of grad school, and it was with an HIV/AIDS service organization. And the executive director asked me if I felt comfortable having the word AIDS on my resume, because that's a big black check mark on my resume that I've worked with people
Really?
living with HIV/AIDS. So stigma,
Wow.
and I think especially when you're working with the most marginalized communities, which people living with HIV/AIDS are the most marginalized. People who use drugs are some of the most marginalized members of our communities. Stigma follows them everywhere that they go.
Mm-hmm.
And stigma absolutely kills people because it stops them from coming into our door for care. So I think some of the steps that we can take is the language we use, making sure that the language that we use is not stigmatizing people. So you'll notice I don't call people substance abusers. I don't call people addicts. That's stigmatizing language, making sure that we use person first language. So people who use
Mm-hmm.
drugs, person who uses drugs, not using words like junkie, right? That's such a stigmatizing word. Not using the words clean and dirty. I think a lot of times we use, I consider it slang when we're talking about your toxicology screenings, and we should be using really clinical language. That's a clinical test that a person takes. It's not clean or dirty, it's positive or negative. So their
Mm-hmm.
urine was positive for, their urine was negative for. I think that's really important because if a person is clean, they used to be dirty, and people aren't dirty.
Mm-hmm.
We're not dirty people.
Right.
So I think really the language that we use matters. The way that we talk about people who use drugs matter. And just really recognizing people's humanity and recognizing that people, regardless of whether they use substances or not, are worthy of dignity and respect, and starting there. It takes a lot of work. We all have a bias, right? And I think it's, as service providers, it's recognizing what our own bias is and being able to talk about that bias and work through it.
Mm-hmm.
You're not one of them, but the media has a really good job of stigmatizing people who use drugs. If you look at
Mm-hmm.
the New York Post any day of the week, you will see horrible headlines referring to people who use drugs as junkies. That is,
Mm-hmm.
it's so inflammatory to use that. I understand it sells, right? It
Right.
sells newspapers, but when we hear that language, I think it's on us to correct people's language and say, like, this is the reason we don't say addict. This is, there's a reason that we say a person with a substance use disorder. So
Mm-hmm.
I think that that's a huge way that anyone can address stigma and work to destigmatize drugs and people who use drugs.
Yeah, absolutely. Language certainly matters.
Yeah.
So can you provide some specific examples of how harm reduction is successfully being implemented in New York State to save lives?
Absolutely. I mean, I think New York State is at the forefront of harm reduction, is at the forefront of addiction services around the country. We actually have a number of our colleagues throughout the country reaching out to us and asking how we've implemented this. Just some really basics that we've done, since 2006. Here in New York State, we've had the opioid overdose prevention programs, meaning, I'm not a clinician, I'm not a doctor, I'm not a provider, but I can access naloxone. I can access a medication that can save a life. So that was something that we did in 2006, and we've expanded upon that. So now OASAS is making naloxone available to all OMH, which is our Office of Mental Health, and all OASAS providers and New Yorkers, right? Through a website that they can just go in, give us their information, and we'll ship them out some naloxone. We've made fentanyl test strips available to all New Yorkers and all of our providers, which when over 80% of fatal overdoses have fentanyl on board, really important to make sure that people who use drugs are able to test their substances to see if fentanyl is on board. And if it is, be informed of their substance and be able to make a decision based on that.
Right.
Something I'm really proud of, the state does not move quickly. We are slow to move, but we were very quick to pivot when we started seeing xylazine show up in our drug supply to make xylazine test strips available to people who use drugs, right? So we're not just focusing on opioids, but what other contaminants are in our drug supply. Our partners in New York City at the Department of Health and Mental Hygiene, and then our partners at the State Office of Drug User Health, which is a part of the Department of Health, have created drug checking projects. So again, people can bring their substances that they have and have them tested to see what's in that substance so they can make an informed decision on their use. I think that's really important. We have a long history, over 30 years, of syringe service programs, which is overseen by our partners at the Department of Health. We have over 30 syringe exchange programs throughout the state. So not only in New York City, but we have syringe exchange programs in Western New York and the North Country, really focusing in on getting these life-saving tools to people who use drugs. I am from Kansas. That's where I was born and raised. And there's not one syringe exchange program in Kansas in 2000.
In the whole state.
In the whole state. And we have over 30. I think that's something to be really proud of. We have expanded access to medication for addiction treatment, or MAT, into all New York State jails and prisons. So if a person has opioid use disorder and is incarcerated in any of our jails or prisons, they have access to MAT. They have access to life-saving medication, which seems like a no-brainer. Like, how are we not doing that? But we weren't doing that. And we recognize this is a very vulnerable population. We have to do something with them. And then making sure that when they're discharged, from jail or prison, they're connected to a provider that can continue that MAT. So I think that's really important. And then I will say, talk a little bit about the overdose prevention centers that are housed in New York City. These are not overseen or funded by OASAS or the Department of Health. And I should make sure to mention that Governor Hochul has not taken a position on overdose prevention centers. So these are not legally operated.
Right.
But a tenet of harm reduction is you do what's right, not allowed. And On Point, who operates, and they are the only two in the nation, the only two overdose prevention centers in the nation. They're located in East Harlem and Washington Heights, which have some of the highest rate of fatal overdose deaths in the city, where one person is dying every 3 hours already. They recognized there was a need for these services, and so they implemented the overdose prevention centers, which are new to the United States, but not new globally. There are over 60 countries that have overdose prevention centers. In their first year and a half of operation, they reversed over 1,000 overdoses. That's 1,000 lives that they saved in 1 year. These centers are highly controversial, but they're saving lives. And I think that that's really the important piece to talk about. Controversy aside, our job as service providers is to make sure that our clients are thriving and living healthy lives and living to see another day. And that's what On Point is doing.
Yeah. It's the impact, all these different programs. I mean, I didn't know about all these things you're speaking to, and the impact you're having, the amount of lives you're saving is really incredible.
Yeah.
Um, so to wrap up, what message of hope or encouragement would you like to share with the substance use disorder community about the potential of harm reduction?
Yeah, I think again, we're not new, but we're really working to expand what harm reduction means and making sure that everyone has a seat at the table. So I think now that our division is here and we're growing and we're able to truly focus on harm reduction, I'm hoping we'll see more harm reduction programs throughout the state and save more lives. I'm really excited that we have this naloxone distribution project going on and truly saturating the communities with naloxone so that if someone does see an overdose, someone is there with a life-saving medication to be able to save them. I think it's being embraced more, which is really exciting. Unfortunately, I think it took us, losing one person every 5.5 hours for people to see why harm reduction is so important that we've got to this place. But I'm really hopeful that the tide is changing, that more people are aware that we have to do something, that it can't be business as usual, and that we're all hands on deck to do this work. There's this great TED talk that I talk to everyone about. I need to give Johann Hari like money. I talk about him so much. But it's the sociologist, his name's Johann Hari, and he did this TED talk that is called Everything That You Know About Addiction Is Wrong. And he ends it with saying, this whole time we've been singing war songs about drugs when what we should have been doing is singing love songs to people who use drugs. And I
Mm.
think that that's where we're at. I think that we're recognizing finally, like, we have to be providing love and compassion to people who use drugs and not shutting the door on them, but keeping our door open for them and working every single way we can to engage them, to help them change, to help them implement any positive change in their lives and be those agents of change. That's the hope that I have. I truly am hopeful that we can do something to stop the devastation that our communities are experiencing.
That's a great message, and you're certainly putting a lot of work into making that hope, that message come true.
Yeah.
Um, I want to thank you so much for taking the time to speak. It's been a pleasure to learn about all the wonderful work you and OASAS are doing with harm reduction.
Yeah. Thank you, David. I really appreciate this.
And for those watching, for more information about harm reduction initiatives and resources from the New York State Office of Addiction Services and Supports, please visit oasas.ny.gov/harm-reduction and stay tuned for our next installment of Behavioral Health News Spotlight on Excellence series.